Well, in my introductory few slides, and I actually hadn't intended to use this one, but it's an apt thing because when we began here 32 years ago, and because I was the founding associate director for medical oncology, interested then already in a very focused fashion in melanoma, and with the director of the Cancer Center who is an immunologist and interested in ways to use immunology to treat this disease, no one had anything that changed the outcome of melanoma, either progression, that is the time before it gets larger, or mortality, the time before it would be lethal to the patient. And even 6-7 years ago, as you may hear from subsequent speakers, we had nothing in this disease that changed the outcome. So it's really a testimony to the tenacity of the people who've undertaken this effort that we now have 13 approved, FDA-approved therapies, most of which we think have, of the new therapies, an impact both on the time before tumor enlarges, progression-free survival, or on survival, and ideally on both, and now several different ways to treat the disease when it's been operated but has a high risk of coming back, the so-called adjuvant arena. And the revolution is no time soon going to change this pace of added new agents. We expect before the end of this year we'll have at least a couple of new agents that we already know are in the hopper for the FDA. So the question that used to be what to do because we had nothing now becomes what to do because we have so many things to do. The prioritization of each of them becomes an issue. And I'm going to skip over that for a minute and just to say, you'll wonder how we sit here in Pittsburgh in relation to our efforts in melanoma. And the core of this is the building and the unit that we call the Pittsburgh Cancer Institute, the bottom of this, Venn, sort of Venn diagram. But we work through a cooperative group where we've focused huge efforts over the last 30 years, and I've had the pleasure to chair this melanoma committee in the National Cooperative Group called ECOG. It's now called ECOG Akron because the Eastern Cooperative Oncology Group got married to the American College of Radiology Informatics Network. But that's a long story that I won't bore you with. But the international working group that Val mentioned briefly is actually a forum of the 15 largest melanoma centers across the world, is also hubbed here, and we think about literally every day. So this is a very well integrated effort, and the phases of the disease you're going to hear about today from the faculty, from our research coordinating nurse supervisor who brings all the trials to each of you, from our research registrar, Carrie Trent, who updates the information on all the banks that we have, which are critical to the advances that Val mentioned with tissue studies that really, if we don't have the information, are as useless with the tissue in hand as even if we didn't have the tissue. And the Mount Everest of our disease is this red part of the triangle, advanced, unresectable, metastatic disease. 9,000-10,000 people a year who developed this in the past routinely died of it, and now we actually have therapies that we think can cure some of them. Already 30 years ago we said treatments that work a bit in metastatic disease in the red part of the triangle, maybe they work a little better if we use them for earlier patients who have operable disease but have a high risk of relapse. And so that'll be what Dr. Tarhini talks about in terms of adjuvant therapies that are now 3 and we hope very soon 4 or 5 options before us. And what our dermatologists focus upon, what our primary care physicians, what all of us in each of the disciplines I've already mentioned worry about is the patients who have a skin lesion that could be operated, could be detected earlier if we just informed our patients, our primary care physicians, and our specialists. And in fact, a patient who's had a prior melanoma has a higher risk of a new melanoma. So all of this prevention business is even still applicable in someone who has adjuvant therapy. And so I guess I wanted to just introduce the forum and say that the interdisciplinary efforts in this disease, which are really begun at the level of the earliest detection in, as you'll see, more than half of patients by patients themselves or by their family members, is a critical part. And one of the things that's amazing about our interdisciplinary activities is that if you ask Dr. Holtzman, our surgeon, he could probably give you the talk on adjuvant therapy. And if you ask Dr. Tarhini to give the talk on surgery, he could also probably give this because we work so closely together. And happen chance today has it that Dr. Ferris, who is our dermatologist, isn't here. So I'm going to be giving you our dermatology talk just to prove that we can actually each take each other's coat of arms and carry it forward, and I hope do a reasonable job, because you can't take care of melanoma in the advanced setting without thinking about prevention. And the same is true reciprocally, that somebody who is looking at patients with early melanoma has to always be thinking about higher risk disease. What about the lymph node station, and all of what you'll hear from Dr. Holtzman and Dr. Tarhini. And then, since you've already asked for something about the cutting edge, the work in immunology is really where some of the most dramatic progress is being made. The efforts that Dr. Zarur will discuss are really the future, the third and fourth generation of the agents and the treatments that we talked about today. So with nothing more ado, I'd like to talk about early detection of melanoma, the bottom of that pyramid that I showed you, and say that this is critical for all of us in each of the disciplines, but it's even more critical for each of you, because whether you're a patient or your family member, we need eyes on our back. We can't see our back. We really depend on family members, spouses, children, to keep an eye on the skin, because that's where the first action is. And so the incidence of melanoma, as I think we've talked about, and each of us could certainly talk about, risen more rapidly than any other solid tumor. Here are statistics that are already a few years old, show you this rising incidence, and in men, rising mortality that is still a problem in this country. Good news comes from down under, in New Zealand, in Australia, where they've been thinking about prevention, about early detection for already 30, 40 years. This trend has begun to blunt. And so the new melanoma incidence in Australia, in New Zealand for the first time, has leveled off and may even be falling. We have projected data for the US, for the United Kingdom, for Europe, and sadly, for at least a generation to come, this rising incidence is not going to change. So if you detect melanoma in advanced stage, this yellow line is the curve for outcome. We know historically the lethality of this tumor. Earlier disease, stage 3, the dark blue, is where the surgeon can operate disease, but we know the surgeon does and medical oncologists do. According to the features that Dr. Holtzman and Dr. Tarhini will talk about, we can predict a significant fraction of those patients will have relapse and mortality from their tumor, even though it can be operated. So where we really want to detect disease is stage 1, and even more frequently out there in the population. So if there are 60,000 melanomas, invasive melanomas in these 4 groups, there are 70 or 80,000 that are melanoma in situ. So detecting melanoma in situ meaning before it has the ability to jump on the train, get into the lymphatics, jump in the rivers, get into the bloodstream. Detecting melanoma in situ should be the goal that we all have. Because if we picked up melanoma in situ, no one would die of this. So the 10-year survivals you see are now well predicted from the algorithms of staging that have to do with the thickness in the skin. This wavy line is the area between the upper layer, the epidermis, and the light pink, the dermis. And this is where your melanocytes live. Melanocytes are pigment-making cells. When we stain the tissues, they crinkle up, and so they look like little donuts. But every 8th cell in all of our skins, whether we're of any race, regardless of the pigmentation, every 8th cell is a melanocyte. And this is where the transformation happens when ultraviolet triggers genes that activate the progression capacity of the cells, and where the capacity then to spread first through the lymphatics, as Dr. Holtzman will talk about, and then potentially also through the bloodstream to cause the problems that advanced disease has. So the importance of early detection is that the time delay that a pigmented lesion has been in the skin is very clearly associated with the risk of dying. The 10-year probability of dying for patients who have a lesion that has been in place 12 months, as you see here, is a median of 6.8%, whereas early detected within weeks is 1%. And so you see from this the importance for making quick action, quick diagnosis, quick surgery for patients. And the probability for dying of a very thin melanoma, as you see here, is very low, whereas a thin melanoma not excised within a year that has gotten into the deeper parts of the skin has as high as a third or more chance of spreading, of causing death. So the problem in melanoma is, in contrast to other diseases that you know we have prospective screening trials, there are no prospective randomized screening trials where one group was screened, one group wasn't screened, and we can show you differences. The kinds of studies we've done have been time sequence studies in areas in Europe and now here in Pittsburgh, where we're actually trying to detect disease early by training primary care physicians to look at the skin, by training patients to look at the skin, by training family members to look at the skin, and then to act earlier. Evidence for this is that people who have had a full skin examination historically within 3 years of their visit with a melanoma have better prognosis than people who have not had a skin examination within that frame of time. In Germany, a study called SCREEN out of Schleswig-Holstein, a little state just underneath Denmark, between 2003 2004, the residents over 20 years of age were asked to come in if they had national health insurance, which is pretty ubiquitous in Germany. They only got about 19% of people to come in, so even there it's hard to drag or to whip people in to get screening examinations. But they did something else. They actually trained all of the primary care physicians in this area, and they were bold enough to do this in a face-to-face 8-hour on-site training session, after which dermatologists and primary care physicians were charged to do physical examination with total body evaluation. And they had a small incentive, an insurance, if you will, payment incentive that prompted them to do this even more. So they got very good participation by their dermatologists. 2/3 of non-dermatologists in this state who took this training, amazing, I don't think we could come close to that here, and with a very large population for the entire state and 360,000 people who were screened either by dermatologists or by non-dermatologists, what they came up with was 15,000 lesions that they thought needed to be excised, and a yield that was significant for melanomas amongst this population. Well, when you look before they did this, this screen project and say what was the incidence of melanoma detected per 100,000, what you see among women in red and men in blue is a pattern which I think is some evidence that the screen project had an impact. But 90% of the melanomas they detected in this screening effort were thin melanomas less than a millimeter, the very first, the lowest stage we know. And so the projection from this already was, because they were seeing thinner melanomas, they might see better outcomes, less mortality. And so when you look at mortality in the same exact study over the same exact window, what you see is this drop in mortality in men, a less dramatic one in women, but a net reduction in the end of mortality that was nearly half. And so this is the impetus that when this data was published now 3 years ago in Cancer, I said we can't avoid not to do a similar effort here in Pittsburgh. We met with the leadership of the UPMC health plan. They bought into this immediately, and they said, we have some very large practices. Why don't we train our physicians not on site, because that would be suicide. It would be impossible to get these doctors come in for 8 hours to take a skin screening training session. But we said through the internet, where we all have to do things for compliance education. And lo and behold, we did this. Oh, here is the data that shows you that mortality risk. This is Schleswig-Holstein, SH, before the screen, and SH after. The colors show you the mortality in the population, and this is just the evidence that the mortality fell in Schleswig-Holstein. It did not fall in Denmark, which is dark, this higher rate of mortality, did not fall in Mecklenburg and all the other states surrounding Schleswig-Holstein, only in Schleswig-Holstein. And there are questions about this. This is one state. It was a time series study. It wasn't a randomized study, but it is certainly prompting. And so we actually began the training of our physicians late 2013. We piloted this. By 2014, we're asking all primary care physicians in the targeted practices to take an hour and a half on the internet training module. And in fact, we had an amazing uptake amongst the largest practices for this. And we saw screenings begin as they could track them also through the electronic medical record. We had 50,000 screenings in target time for the first year, 2014, now approaching 100,000 screenings, and amazingly, 66 melanomas detected by those primary care physicians through their educated early intervention to achieve biopsy in these patients. So, are there downsides to this? Were we doing zillions of biopsies in people who didn't need them? We actually had the availability of the health plan data to look at this, and there was no rise in the biopsy rates for a variety of things that we would have worried might have blunted or reduced the efficacy of this. So there's benefit from the screening and from the interventions of the primary care physicians without any undue rise in the biopsy efforts, the healthcare costs. So you've all seen this. Are we screening the right people is a real question we have to ask. Who gets melanoma? On the left, people with melanoma diagnosis, 59, 60 years of age, a bit higher diagnosis in men than women, as you see here. Higher socioeconomic status, perhaps because those are the people who go out to lie in the sun in the Bahamas, and a highest incidence in non-Hispanic whites. Who dies from melanoma? As you see here, the older, the higher the risk. Again, males more than females, and disproportionately high for men, but unfortunately low socioeconomic status, and perhaps people who have delays in getting to care. And when you then ask, how about who gets screened for melanoma, you see that it's a very different population. It's many younger people who get screened. It's more female than male. We have to educate the male segment of the population because this is where the mortality is rising, as I said before. And again, it's highly educated and 95% white. So we have a job to do in educating the population as to whom should get screened. I hope through teaching all of you to go out and be our missionaries in the community, you will say, get the older guys in, because that's where the payoff really will be. So, melanoma in older men, incidence of thick melanoma significantly higher. The AAD has asked for screening to be focused upon these portions of the population. They are only 25% of the people who are screened, but they're 44% of the confirmed melanomas. Overall, the pickup of a melanoma in a screening effort is 1.5 per 1,000 screenings. If you're just looking at men over 50, it's 2.6. So we've got a higher lethality, a higher detection rate, a greater efficiency of screening. And if you ask, what's the likelihood that a 60-year-old guy will develop a melanoma in the next 9 years, it's 5 times higher than the baby born today will be in the next 40 years. So huge differential risk, huge reason to consider, again, focusing our screening on these kinds of patients. So the yields, screening under 30, if you ask how many people, number needed to screen, the NNTS, how many do you need to screen? If you're looking at people under 30, it's 3,000 you need to detect a skin cancer. But if you look over 60, it's 25 to detect a skin cancer and 170 to detect a melanoma. The payoff is much higher. This is why we think the older population, the male older population, needs to be targeted. So if we can't get people to come in, maybe we can get people to look at their own skin. Skin self-examination is something for which there are many algorithms. If you look at the AIM at Melanoma site, that's a place where you can find education. If you want, I'm happy to provide, and we have in the clinic, information for self-examination. But when you look at the detection rate for melanoma, it's mostly patients who detect their own melanomas. And so studies at Memorial, Hopkins, the Italian Melanoma Intergroup, the University of Pittsburgh show you 60%, 55%, 57% of melanomas were detected by the individual who had the melanoma. So this is a place where education may pay off in ways that we really still haven't tapped. I think if you ask skin self-examination and the risk of the melanoma, the odds ratio, OR, that you will have a more favorable melanoma, people who do no self-examination have what they call unity, the baseline risk of a melanoma. Those who do self-examination reduce that risk by a significant margin, down to 0.68. If people do monthly, once a month for a year, that's 11 in a year, it's down to 0.39. So the likelihood you'll pick up a favorable melanoma if you're doing monthly self-examinations is much, much better. What are you looking for when you're looking for a melanoma in the skin? Well, you know, we used to say A, B, C, D. I'm going to tell you today, remember that because it's unforgettable, but sideline it, because much more important than any of the ABCDs, the asymmetry, border irregularity, color variegation, or diameter, is evolving, or E, N for new, and the bottom, U for ugly duckling. So if you just think E, N, and U, evolving, changing lesions, new lesions, and ugly duckling lesions, these are the most sensitive and specific things that we can teach you to help you to diagnose an early melanoma. So the inevitable pictures, asymmetry, I think, needs no further description, neither border irregularity, color, or diameter. So these are useful indicators for what a melanoma would look like, but we don't want to wait until it's a melanoma. We want to pick it up before it's become invasive. So evolution, variegation in coloration, and new lesions, of course, and then the ugly duckling. Patient who has 100 pigmented lesions on the skin comes in and says, help, can I take all of these off? You don't need to. You need to figure out which is the ugly duckling, which is the one that is the outlier compared to the other lesions of the skin. And this is one example in the lower right that I can't, there we are, which is clearly different than the other pigmented lesions of this patient. Each time we see you and each time your dermatologist and your primary care physician sees you should disrobe, because you can't see it if you're not disrobed. And so that's, I think, the lesson. Many, many different faces of melanoma. These are all melanomas, but they're all different from one another. And so how to improve the outcomes? Early detection. Public education. This symposium today is part of the effort and will be every year as long as we can keep it going. The effort to have you understand what we're looking for, have you help to detect the lesions that may emerge. Equally important, healthcare professionals need to be educated. So the internet module that we have is a thing that is accessible from anywhere through the internet. and we're pushing it out and trying to train and new waves of education for primary care physicians. A primary care physician who sees you and says, I don't know what I'm looking for, please go to see somebody else, you should really say, because you have the power as the patients, as the family, learn, it's out there. So technology may help us, and I'm going to skip quicker over this because so far we don't have any technology. The bottom line of what I'm going to say in the next short module is that we really rest upon the sensitivity and the specificity of our eyes and our hand lenses that allow us to look at skin lesions. But we can't tell what was there 6 months ago or 6 years ago if we don't have that documented. So as many of you know, beginning in about 2002, we set up a server that was secure, IP address protected, incredibly secure. In fact, they didn't let us do this until the Pittsburgh Steelers needed their orthopedics films sequestered. And then they said, Melanoma program, you can finally have your server for your patient total body photography. And these are just a selected 8 or 10 pictures out of 35 frame set that will be done and is available for anyone who has more than, say, a half dozen moles that we just can't hope to track without this. So we set this up. We have a medical assistant for men and a medical assistant for women who are dedicated once a month to do this. Anybody who's worried about being able to track their skin lesions, I invite you to ask us to schedule you or ask our clinic nurses, because this is something that we have available for everyone here. The tools that we use, the dermatoscope, more for dermatologists than for primary care physicians or non-dermatologists, but you need to see the lesion if you're going to make a discovery of melanoma, and sometimes the light and the magnification that these devices provide is the only way to see the lesion, and there are handheld tools that allow smartphones to be used to document these. We do it with a bigger, heavier camera, but it's the same goal. What do we see under the lens? You see this, where this is what you see under the naked eye. The difference is that this avoids reflection. And so part of the problem with looking at a skin lesion when you look with your naked eye is that all the light that reflects obscures what's going on beneath the skin, and a dermatoscope, through directly applying to the skin, or a dermatoscope with an oil layer between, allows you to see through the skin and to magnify so that these changes in a part of the lesion, which is clearly doing different things than the rest of the lesion, allow you to say, maybe this needs to be biopsied. A device that you'll all have probably heard about called Melifind was approved as a device, not as a way to detect melanoma, back already 5 years ago. And they do use 10 different wavelengths to penetrate different layers in the skin and to provide different images. Unfortunately, when they have published their data, they're pretty good at detecting melanoma, 98%, but they are not so good in specificity, calling something that is benign. And in fact, when this was discussed in the Times a few years ago, the false scores as positive, calling everything melanoma when it ain't, was the problem that was really honed in upon, and the reason that we still don't regularly think this needs to be applied, because if you call everything melanoma, you won't be wrong about the melanomas, but you put a lot of people through a lot of biopsies that don't need to be done. So I'm going to skip through these because I know we're running over. And these are just more to the things that we've talked about already, to say that you can actually use tape to pull off a layer of the skin and do genetic testing, a very fond idea that we had already 5-6 years ago that is still awaiting validation. But I think we're stuck here. And so when you do that stripping, what you look under the tape or at the tape to see is melanocytes in the skin, the epidermis peeled off the skin, a potentially useful way to define the differences between malignant and benign lesions by gene expression profiling, something that will become increasingly important as we have better genetic descriptors for what is a melanoma. So I'm going to skip all of this and basically say that electrical impedance is a way that this can be done, but the bottom line is an ounce of prevention is worth pounds, if not tons, of the cure. And one thing we haven't talked about is how can you avoid the damage that the UV may induce in the skin? And I think the obvious thing that you all heard hundreds of times, but we need to say at the close of any talk on melanoma early detection and prevention, is that to avoid midday sun, when your shadow is shorter than you are, it avoids UV damage at the worst times of the day. If you've got to be out, good sun protective clothing is something that nobody really violently objects about. So fully brimmed hats, sleeves when it isn't so hot that you can't stand it, trousers are the simplest way to avoid UV damage that we believe is the impetus to melanoma. Sunscreens are a political football, and the SPF, the sun protection factor that everybody talks about, we stress less and less now because all that tells you is how long it takes the skin to turn red in a unit of sun exposure. If it is SPF 30, what does it mean? It means that what redness you get in an hour without the sunscreen, you get in 30 hours with the sunscreen, but it's redness. It's not the genetic damage that we think precipitates melanoma. And we know that the SPF, the redness protection, is not the essence of melanoma prevention, and that probably having blocks, true chemical blocks, zinc oxide and titanium dioxide, which effectively block the sun, far more important than the redness protection. So putting on sunscreen, putting on block sunscreen, not just SPF that's high sunscreen, and putting it on frequently, clearly important to avoiding skin damage from the ultraviolet. I don't think we need to say it anymore, but because I don't want to miss it, avoiding tanning beds because they are not safe. They are not less damaging than the sun is. And finally, now we have a law in the state of Pennsylvania banning this under 17, but it's as dangerous at 27 or 37 as it is at 17. All of us should avoid tanning beds. And the knowledge that we have that you'll hear about on the treatment spheres for metastatic disease, for adjuvant disease, for better surgery, all of the details of the protocols and the registry data today, if we can bring it to bear on the early disease, on the earliest detection of the disease, will be even more powerful. Skin cancer screening saves lives, we think. Early detection equates to improved survival. This needs to be focused upon men, particularly older men. And technology may help us, but right now it's not the essence. It's really just to get patients to examinations. And with that, I'll close. I think we'll save questions, and or I guess we do have a question, but we're a wee bit late. So let me ask if there are questions.